Good afternoon, or good morning, depending on where you are. My name's John Wilson. I'm President of the Royal Australasian College of Physicians. Firstly, I would like to respectfully acknowledge the traditional owners of the land on which we are meeting today, the Boon Wurrung and Wurundjeri people of the Kulin Nation, and pay our respects to elders past, present and emerging. We extend our respect to all Aboriginal, Torres Strait Islander and Maori people, including those present today, and value the importance of their ongoing connection to land, sea, sky and community. And together we restate our shared commitment to advancing Aboriginal, Torres Strait Islander and Maori health and education as core business of this college. Well, welcome everyone, and thank you for joining today's webinar. It's my great pleasure to chair the first shared session in the online Congress series, Healthy Futures, Healthy Cities. I would also like to acknowledge and thank our major sponsor, the Australian Digital Health Agency, for making this presentation possible today. During the next hour, we will be discussing the role of design for health in cities, how we can design and ensure cities are good for people, you may well ask. With the issues of climate change, digital change, viral pandemics, what should we really want for our cities? How should we design them? And what policies are there that the college puts together and enables to allow us to have the best possible environment in which our communities grow? So with these challenges, we've put together for you today a sustainability expert, a digital health strategist, a respiratory physician with a view on the environment, and a futurist to help us answer these questions. During this presentation, we're grateful if you do submit to us any queries that you have that we will put together for the panel at the end. So I'd now like to start by welcoming Tony Capron, who directs the Monash Sustainable Development Institute and holds a chair in, of all things, planetary health at the School of Public Health and Preventative Medicine at Monash University. Tony is a public health physician and an authority on environmental health and health promotion. His very broad range of interests include being a director of the International Institute for Global Health at the United Nations University and has previously held professorial appointments at the University of Sydney and the ANU. He is a member of the Rockefeller Foundation Lancet Commission on Planetary Health and published its report, Safeguarding Human Health in the Anthropocene Epoch in 2015. Tony, over to you and tell us about what's sustainable.
Thanks very much, John. It's terrific to be here today for this interactive session. And I just need to check that the slides will come up. Yeah, that's great. So my role is to open up the conversation today. And I think it's really important that we start with the demography. The population of the world here in billions, UN estimates, from 1950 on the left through to 2030 on the right. And you can see that the purple bars represent the total population of the world. And I find it quite useful to think about this population data from the perspective of my own lifetime. I was born in 1960 there, not far from the left-hand side. The total world population at that time was 3 billion. And you can see from that blue line that 2/3 of the people of the world at that time were living in the countryside. If we fast forward to where we are now in 2030, you can see that with the red line crossing the blue one, that we've now passed the point where more people on Earth now live in cities for the first time in human history. And in the coming years, the next 20 years or so, when many of our training fellows will have their working lifetimes, we'll see continuing growth in urban populations around the world. This is an enormous challenge to manage. How can we make the best of urbanization around the world? Back in 2006, now almost 15 years ago, at the Australian Academy of Science in Canberra, I co-hosted a conference on urbanism, environment and health. And by that we meant urbanism being the way we live in cities what that means for the environment and also what it means for human health. And one of our very eminent colleagues, Professor Tony McMichael, showed this slide at the outset of the conference. It's an historical view of urban health penalties from a developed country perspective. So on the y-axis here, we have health risk indicatively, and on the x-axis, the phases of life on Earth from 1800 through to the present and to the future. So that phases of industrialization in the 19th century, modernization in the 20th century, globalization that we're living through now, and what might be ahead. And so clearly you can see here the big challenges of infectious diseases through the 1800s, control measures put in place in a variety of urban contexts, sanitation, water supply, for example. But of course an uptick in recent years with HIV/AIDS, and now of course the coronavirus pandemic. And then in the middle of the chart, you can see urban air pollution. Again, rising through the phase of industrialization and the rise of the motor car in cities, and then controls in high-income countries have reduced air pollution in a range of contexts. Road trauma, motor vehicle injury as well, on the rise through the latter part of the 20th century, but brought under control with behaviour change and engineering solutions in cities. And then, of course, the rise of obesity and the rise of greenhouse gas emissions at the same time, the rise of mental health challenges. Clearly not sustainable in the way we're living in cities. This was another slide that Tony McMichael showed at the outset of that conference. It's about the challenges when we think from this system perspective, urban transport systems and what they mean for health. So on the left-hand side of this schema, the transport system in a city like Melbourne, partly inherited and reflecting history, but also evolved in the context of our urban planning values, preferences and theories over time. And right through to the right-hand side of the schema, a range of potential health outcomes that connect to the transport system. And in the middle, you can see that the transport system influences energy needs. There's a range of modes, associated infrastructure, and then we end up with levels of air pollution that reflect those modes, that infrastructure, greenhouse gas emissions, noise, a lot of urban noise coming from the motor car, of course, but also questions of walkability and safety in the landscape. And then you can see a list of different medical conditions on the right there that flow on from the way our urban transport system works. One of the things that came from that conference, when we tried to put some order into what we were discussing at the meeting at the Academy of Science, was this framework for urban sustainability and population health. So you can see here a grid, and on the top axis, we divided what constitutes a city into 6 broad subsystems: the economy and work, transport and urban form, housing and buildings, water and sanitation, nature and landscape, media and communications, and the cultural and spiritual dimensions. And when we think about cities and we plan them and develop them and manage them, as the City of Melbourne does, as other governments at different tiers do, many folks are focusing on one of these subsystems, perhaps 2. On the right of this diagram are a number of what we might call determinants of health in the vertical there to the right. The air quality, water, noise, infection, allergens, chemical exposures, local climatic conditions, food security, physical activity, safety, family relationships, and social capital. In public health, we refer to these as determinants of health, both our physical and our mental well-being. The point of a schema like this is that in the middle, we have a range of cells here. And in those cells, we can ask research questions, policy questions. We can shape our practice. And we now use these kinds of schemas in the work we do in health impact assessment. And this brings me to a key point, the need for systems thinking when we're thinking about the links between human health and cities. It helps us understand the dynamic interactions when we're working across sectors. It helps us understand feedback, policy resistance, why we're stuck with big challenges like obesity. Where are the leverage points for change, and what might the unintended consequences be from those changes we make? I'm getting a little bit of a wind up here from John, so I might stop my slides here, but perhaps just to emphasize that when we're thinking about systems, we can come back to the transport system, we can think integratively about the decisions we make on the left-hand side of the schema and what they might mean on the right-hand side of the schema, thinking integratively. The approach we use is collaborative conceptual modeling with 2 phases, 6 steps. What's the challenge? What's the story? Can I see how you think? What's driving system behavior? Where are the leverage points? And can we have new eyes on the problem? So we're now working with international colleagues on this work, including through the Chinese Academy of Science. So just to give you a bit of a flavour of some of the work we're doing in this context. Thanks very much, John.
Thanks very much, Tony. I think that's given us a very good foundation to ask about the questions of what is really sustainable in the way forward. And to help us with that and thinking through the digital solutions that are available to us today and may potentially be there in the future, we do need to think through what about our national digital health strategies? How are our policies able to interdigitate with health planning? For example, telehealth, very topical at the moment. Electronic medical records, we've all got them, or have we? The person that I'd like to invite now to discuss this is Clinical Professor Meredith Makeham. Meredith is the Chief Medical Advisor for the Australian Digital Health Agency, our sponsor today. Meredith has been a spokesperson for this organisation for some years and has a major interest in those topics of electronic medical records and telehealth. She has also been central to the collaboration of governments and agencies from 25 countries and the WHO that share policy initiatives and information that relate to digital health services in our countries around the world. One of her key responsibilities includes oversight of clinical governance of the My Health record, something that will be helping us into the future as we collate an enormous amount of information. It's my great pleasure now to invite Meredith Makeham to address us today. Thank you, Meredith.
Thank you, John, and good afternoon. And it's a pleasure to be here virtually to talk to you about the way digital health is supporting healthy cities and better connected care for people, and supporting the way also that we're responding to the COVID-19 pandemic at the moment, this crisis that we're all dealing with as healthcare providers. So as you've heard from my introduction, I'm the Chief Medical Advisor here at the Australian Digital Health Agency. And I'm also an academic at Macquarie and Sydney Universities with a background in digital health and patient safety. And I'm a practicing GP. So my perspectives about the real value of these tools are informed not only by my involvement with their operations, but also by that reality check that I get each week that I have in my own practice and speaking to my colleagues and patients and my physician colleagues, of course, as well. Look, I know that a lot of you will have had some experiences with implementing digital tools in your own practices in hospitals, and they've often left a lot to be desired in terms of user-centred design and integration with other systems. And you know, that's a really important point to make, because supporting healthier communities and better connected care, it's an interoperability story, and there's still a long way to go there. But it's really important that as practicing clinicians, we're engaging with industry and government to continually improve the systems that we have and make sure that they're fit for purpose in a modern, digitally enabled society that's aiming to reduce avoidable harm for people. And I've been really pleased that the Australian Digital Health Agency has been working really closely with the RACP over the past couple of years. We've developed various education tools in this area, and we're currently working together on a specialist digital health toolkit that I really hope will help people who want to step up some of the digital tools they're using in their practices to support telehealth during COVID-19 and other aspects of better connected care, electronic prescribing, My Health Record, secure messaging, etc. So today, look, just going to jump to the next slide here. So let me take you on a quick tour of some of the things going on within our Department of Health and Agency that are supporting our drive to give people better connected care. And I wanted to begin here just as a bit of a context for your background. It really frames what we're trying to do across a range of different programs of work. It's our National Digital Health Strategy, and this was agreed by all Australian governments in 2017 and gave us a 4-year roadmap of where we wanted to get to with respect to digital health services. And there was an extensive consultation on this planning. Clinical peaks and colleges were involved, clinicians, patients, academics, industry, governments. The RACP was involved in shaping this. So I'm not going to go through it all in detail today, but I think that that's an important context, and some of the things I talk to will be sitting within those various pillars of the National Digital Health Strategy. The first part of the strategy, the first pillar, is giving people health information that's available whenever and wherever it's needed, and that's the My Health Record system, which has had an interesting history over the last 7 years, 8 years actually, of operation. And we've really seen the way My Health Record in particular has shone in a crisis for people more recently. So both with our response to bushfires and floods in terms of the environmental impacts on the community, people who were evacuated and cut off from their homes, their pharmacies and their general practices were saved from potentially quite harmful gaps in receiving their medications by doctors, nurses and pharmacists who are actually in evacuation centres able to look at My Health Record and provide correct medication supplies to those people who were stuck there for days or weeks. And it would have definitely reduced medicine safety events that could have led to patient harm or worse. And we've got lots of reports of the way people use My Health Record, patients and clinicians during that time. This is just a big picture overview with a few stats. Things have actually rapidly changed over the last 12 to 18 months with respect to how much information is in the system and how many people have one. And the big engagement as well has been driven by COVID-19. I think people wanting to be able to support telehealth consultations and have online access to more information. But you can have a look at our website that's got these big picture statistics on it. But to point out to you, we now have 22.75 million Australians with a My Health Record. That's over 90%. That was after the opt-out period that finished over a year ago now. And about 70% of those My Health Records have got clinical information in them. So it's getting a lot richer than obviously before everyone had a My Health Record, and we're getting much more connections going on around the country, which means that there's a lot more value in it for you. Just now go and take a look if you're interested in the system. And just to remind people, it's a secure online summary of your key health information. It's contributed to by connected healthcare provider organisations. It's got medicine and allergy information, discharge summaries, pathology, radiology reports, GP summaries, advanced care planning documents and immunisations. It could have event summaries and letters from specialists in it as well who are connected. And there are some of those that are connected and using now, but early days there, and I'll talk about that in a minute. So in terms of how people themselves are using it, we've got obviously lots of people now jumping on and contributing their own medications and allergies and advanced care information, but you can look again at those details that are all online. And I think the next iteration of this is coming out. In fact, as I speak today, there'll be an update on these statistics. And just briefly to touch on the subject of how physicians are using it, how our healthcare providers are actually using the system at the moment. So currently we have about 94% of public hospital beds connected to the system if you count by beds, or 91% of hospitals, and 92% of GP organisations registered and 91% of pharmacies registered. And, you know, specifically regarding private specialist use, private practice use, so not if you're looking at it from the hospital, but if you want to look at it from your rooms, we currently estimate that the figures are really pretty low and that we've got about 10% of private specialist rooms registered and probably only about 4% actually viewing or contributing information to the system. So look, why would that be, or what might that sort of prompt for you, thinking about how to get this better connected care going on, and if you're interested in engaging in that from your own rooms? Well, currently it's really very low compared to other sectors, and there's a lot of historical reasons for that, not the least of which is whether or not your software provider has added My Health Record functionality to the product you're actually using in the rooms, if you are using a clinical information system. But these interesting diagrams that I've just thrown up here, they show specialist rooms compared to other settings, and they're called river plots, and they show who's putting information into My Health Record on the left, and on the right they show who's looking at it. And the specialist dot, it's a little hard to see, I'm not sure if I've got a pointer that you can see, but up on the top right of the 2019 one is the word specialist, but you can see there's no thick line next to it, and that's just indicating that we're not getting much input or much viewing yet in the specialist sector. Now, of course, connecting up care around our patients is a key requisite for getting benefits out of our national digital infrastructure in this system. So thinking about supporting health communities needs specialists connected, of course, around their patients, as well as all the other parts of that story. And as I mentioned before, your own software could be the barrier between you and connecting to My Health Record, and that's a recognised issue. So the private software market is what we want to drive in terms of improving the functionality that you've got so that you can actually connect with these systems and do electronic prescribing and secure messaging and other things like that. So we're really trying very hard to work with the specialist vendor software market to upgrade their software so you get those functions. And these products are actually going through an upgrade at the moment, so watch out for those who are using any of those. And it's important to remember, I think I'll say this, as the customer of those private software vendors, you should heartily complain if you feel that your product doesn't do what you need to do in terms of being able to use various tools like electronic prescribing or look at My Health Record. And there's a lot of feedback we get from vendors at the agency that say that their customers, that's us, the doctors, the physicians, aren't asking for various features, but it's very hard for you to ask for something that you didn't realise you were missing. So it's a bit of a catch-22. So a lot of the toolkit work we're doing with the college at the moment is around upskilling you in terms of digital literacy and being aware of what those new digital health innovations are that you might want to start engaging with. Now, in addition to electronic prescribing and My Health Record use, you'll need secure messaging, which is key to the way we get safe and secure communications about our patient health information. And there's been a new system developed recently, which is called the Service Registration Assistant, which is working in the North Coast of New South Wales. And it's a really nifty sort of piece of middleware, if you like, where you put your practice details and all of your information about your address into the system, and then any hospital, practice, secure messaging system, anyone can access this. So you don't have to keep your details up to date in all of those different systems and address books around the country so that you can do secure messaging. So we hope to see that rolled out nationally, which will really improve the ease with which GPs and specialists and hospitals can communicate around our patient care. And of course, strongly related to our conversation today about healthy communities is our Communities of Excellence program of work. As part of our enhanced models of care pillar in the National Digital Health Strategy, that's the bars across the top there, the agency is running this Communities of Excellence program, and we have 2 communities where we've had an intense focus on connecting up all of the healthcare providers in the system so we can really see benefits flowing to people and their clinicians and test drive some of the services that we're looking at scaling nationally. Now, one of the drivers for our Community of Excellence work is thinking about the ways to reduce vulnerability for people. And this is something measured by the Australian Institute of Health and Welfare, and they've estimated that it's at around 30% of Australians. And vulnerability is a determinant of poor health, which can be compounded by poor English proficiency, low socioeconomic educational status, low digital inclusion, which is a measure that we use as well. And AIHW estimates that those who are vulnerable are vastly overrepresented in the health system and use around 75% of our $117 billion resource Australia spends on health each year. So closing the health inequity gap and experienced by people in rural and remote communities particularly is a key aim of our Communities of Excellence program, and a reason why our sites for this work are in regional Australia. They're in Emerald in Queensland and Headland in Western Australia at the moment. And we're hoping to achieve that all healthcare providers in these identified communities are registered and connected to My Health Record with regular viewing and uploading. We're measuring to see where digital technology is adding value to clinical practice and providing improved continuity of care for people. And it's about having a test site where we can measure that we're delivering benefits to patients in the community and sharing lessons learned for other communities and run things like digital literacy programs for people in the community. So, look, I'll pause there. I'm conscious of time, John, and I know we've got discussion and question time later, but thanks again for inviting me to be part of this panel today. It's a great privilege, and I'm looking forward to the discussion a little later on.
Thanks very much, Meredith. That has been fabulous and a great insight into what's happening. I think we should just now go to a very short break from our sponsor. Thank you.
Australia's need for a connected healthcare system is now greater than ever. One that's accessible, progressive, and importantly, secure. It means wherever you are, your health information can be safely accessed, as can mental health support. It'll mean you can have your symptoms checked at home, or even download an electronic prescription. Connecting Australia to a healthier future and you to better healthcare.
Authorised by the Australian Government, Canberra.
Thank you. So there are some things that we can do, and we have tools at our disposal to do that. But what about the things that we have difficulty controlling? What about the environment? What about allergens and air pollution? What about things that affect the way our bodies function and are causative for disease? Nobody better to address that topic than Professor Joe Douglas. Joe is a respiratory physician and immunologist that trained at Monash University and is now the James Stewart Professor of Medicine at Royal Melbourne Hospital and Melbourne University. She took up her current appointment in 2012 and now heads an expanding group of researchers and talented clinicians. She has a unique perspective on allergy, lung disease and pollution in the environment. Over to you, Joe.
Okay, thanks, John, and thank you also to yourself and Don Campbell for the invitation to speak at this seminar, which is so important as we live increasingly urbanised lifestyle. I want to talk about three things today. I want to talk about particulate air pollution. I want to talk about biological factors that affect air quality and particularly deal with the thunderstorm asthma epidemics, which have been so marked in Melbourne. And then finally think about what we can do as clinicians and also what we can do as communities helping our patients. So let's run through this because it's a lot of information in a moderately short time. The first thing to note is that air pollution is toxic. How do we know this? Well, there's an awful lot of information, but let's deal with one of the more recent papers that looked at over 650 cities in 24 countries with over 30 years of data that was recently published in the New England Medical Journal. And what it looked at was particulate air pollution, PM10, those particles that are 10 microns in size, and PM2.5, which are the 2.5 micron particles. And these were measured daily and correlated with all-cause mortality as well as cardiovascular and respiratory mortality in this retrospective data set. It was also corrected for other air pollution factors. And what it found was that there was a linear rise with both PM10 on the left panel and PM2.5 on the right, showing an increase in mortality that was throughout the whole increase in these particulate air pollution quantities. If you look also at the vertical bars in this graph, that is the lines that are the recommendations from various global bodies on the threshold for the acceptable, so-called acceptable limits of these particles. And you can see that for many of them, there's actually quite a significant difference in the 2-day average mortality when there's increases. And certainly there does not appear to be a safe level of these particles in relation to mortality. So what does that actually mean for a 2-day moving average? There were certainly independent associations between particulate air pollution and mortality, so that for PM10, all-cause mortality, for every 10 microgram per metre cubed increase in PM10 particles, there was a 0.44% increase in mortality for that day. And for PM2.5, it was even more toxic at a 0.68% increase in mortality. And whilst this doesn't seem much, it's notable this was a daily increase in mortality. So mortality was strongly linked to this increases. Similarly, you can see that both cardiovascular and respiratory mortality was increased with increases in PM10 and 2.5. And so the effect was cumulative with increasing concentrations. And the other thing that was noted in this paper was that the levels in many cities frequently exceeded healthy air guidelines, and certainly the WHO guideline of 50 micrograms per cubic metre. Now, of course, we in Australia, and particularly on the East Coast, have had a dramatic year of vast decline in air qualities in the last 6 months related to the impact of the massive bushfires over the last summer in Victoria. And there's particularly increased PM10 concentrations, and I have a picture there of what it looked like in Sydney, which is just unimaginable really what to compare to what it normally is. And these certainly, we know that increases in bushfire smoke have been studied in a recent meta-analysis by Claire Walter and Lou Irving that looked at increase in emergency attendances on the day of exposure, increase in hospital asthma admissions, and also increase in COPD admissions with a slight lag of 1 to 3 days with bushfire smoke. There's also been modelling, particularly done by Faye Johnson's group in Tasmania, that looked at the increase in mortality related to the bushfire smoke, an indication there were in fact over 400 increased excess mortality that was modelled related to bushfire smoke in the eastern part of Australia, with over 1,000 cardiovascular increased events and over 2,000 respiratory events, so very substantial increases. So if I can switch tack and look a little bit then at biological air pollution, which I best recognise as perhaps the thunderstorm asthma event, which happened in 2016. And in Melbourne was particularly dramatic because within 30 hours of a thunderstorm, there was over 3,000 excess presentations to emergency departments, with nearly a tenfold in additional excess admissions to hospital, many of those in ICU. Those of people who were on the ground noticed that the pharmacies were overwhelmed, general practice clinics were overwhelmed, and indeed supplies of reliever medications ran out in pharmacies. And tragically, and indeed for the first time really in these events, 10 people died. So this was also an epidemic of asthma mortality, bearing in mind that generally only in Australia about 400 Australians die per year of asthma. So there's 3 things we can think about in relation to this event: the weather, aerobiology, and what are the patient factors that are involved. The point about thunderstorm asthma is that there's a updraft related to the weather events which sucks up air particles, particularly biological particles, at the front of a thunderstorm, and this can then be driven downwards. And in Victoria on that day there was a front going from west to east that affected the west of the city first, and indeed that was the area that was most severely affected in terms of presentations, and moved then from west to east across the city and resulted in that flood of emergency presentations. With the aerobiology, pollen grains are relatively large and trapped in the upper airway and rarely get to the lower airway. However, the change in humidity that occurs in a thunderstorm causes smaller particles down to around 2 microns to be respirable to the lower airways, and therefore causing respiratory side effects in those who normally don't have them. This is also part of an annual increase in admissions that we see with asthma and is noted with thunderstorms, and we know that many of these patients, in fact nearly all of them, had hay fever as a finding, and those who were admitted to hospital had higher levels of blood-specific IgE. So what can we say to patients? You can tell them to stay indoors, avoid exercise. You can also help them to have emergency treatments to hand. But I'd like to focus on what we could perhaps help with environmental health literacy to the public, both improving year-round information, enabling people to access information that's relevant to them, and also helping them engage in an individual way with their health so that they can actually access this information better. Thanks, John.
Thanks very much, Jo. So we've got some information about what there is around us that we have a limited capacity to control, but we do need to look to the future. Our policies must dictate better outcomes for our communities. Looking to the future, so important. What solutions are there ahead of us? We've talked a little about electronic health solutions, and now we're going to turn to some other angles that Dr. Lucy Gunn will discuss with us today. She has 20 years of experience in research and teaching in the field of econometrics and urban research. Her key interest is in the understanding of urban environments and supportive health and well-being outcomes. Her research provides us with an evidence base to policy makers and planners on what constitutes good urban design. And linking this together with our previous talks about where we're headed with urban development and how important that is with our community, I'd now like to hand over to Lucy from RMIT University to give us her insight. Thank you, Lucy.
Well, thank you very much, and thank you for having me as well, John. It's a real privilege to be presenting to such a fantastic audience of people out there. I can see there's lots of people online. I'm presenting today on Can a Livable City Be a Healthy City Now and Into the Future? And I'd also like to acknowledge the traditional landowners of the Kulin Nations on whose unceded lands we conduct the business of the university. And I'd also like to just begin my presentation by focusing back on the social determinants of health. So I really wanted to talk a little bit about what is a livable community, because we talk about livability as if we really know what it means, but a livable community is one that is linked to the social determinants of health, so looking at what's around us in terms of those social factors. But from the point of view of measuring what livability is, it's really what is in the environment, which is actually on that outer ring on that very first diagram that you can see there. So when we define it, we are actually talking about a livable community being one that is safe, one that is socially inclusive and cohesive, one that is environmentally sustainable, that has affordable housing, that has access to walking, cycling and public transport infrastructure, and also that is linking to employment, education and to sustainable environments and parks and open spaces, as well as shops and services, and that's good for our health, that has community services and leisure and cultural opportunities. When we put all of these things together, we get what is essentially a livable community, and this is how we define it. But defining it's not the only important thing. It's actually very important to be able to measure it, and I'd like to introduce you all to the Australian Urban Observatory, which has a number of different indicators looking at those very features of livability that I described before. And when you put them all together, we have 23 different indicators, and they're measured at different levels, at local government level, at suburb level, but also at SA1 level, which covers around 200 to 400 households. So very, very fine-grained data. All of this data is actually linked to the the Sustainable Development Goals as well. So this is something that we're trying to do so that people can understand how data fits into that broader framework of sustainability. I thought also it might be good just to draw your attention to a number of reports that we've written on livability, and we've done this for Australia's 21 largest cities, and each of these reports has a bit of a snapshot of what livability looks like. But I thought for today's presentation it might be good if we dug a little bit deeper into one of these measures. We've got 23 of them, we can't go through all of them. So with public open space, we've got a measure that looks at access within 400 metres of parks that are 1.5 hectares in size. So just to give some perspective, that's about the size of a football oval or a rugby field, 1.5 times those. In terms of access to parks for Melbourne and also Adelaide, it's 49% and 47% respectively. They look very similar, but when you dig a bit deeper and look at it from a suburb level perspective, you can see hopefully that Melbourne's quite speckled. So these green areas are where there's good access at a suburb level. These places have good access to parks and open spaces. But when you look at Adelaide, and I hope your eye can see this, there's a bit of a donut. So those middle suburbs of Adelaide do not have good access to public open spaces or to parks, but they do have good access to the north and to the south. Now, this is becoming increasingly important because for many of us, we're locked in social isolation, and it's really what's in our proximate environment that is hugely important and has a big influence on our health and well-being. What we're finding at the moment is that there's a heavy use of local open space, and this article here that's in the conversation can help you hopefully understand a little bit more about that. And I wanted to just dig a little bit deeper into some of these findings more specifically. When we did a study that looked very specifically at an infill development area where there's lots of amenities, so higher density, good access to services, good public transport, good access to public open space, when we compared that to a greenfield site where there's less amenity, we find that there's actually twice the likelihood of walking in the infill site. So you can see here there's 131 minutes of walking in the infill site, which is Altona North, compared to Truganina, which only has 71 minutes. Now, we took these results and put that through a health impact assessment analysis and model, which looked at the chronic diseases related to walking and physical activity. And when you do that, we find that there's health-adjusted life years of 1,575, and that's a form of disability. It's similar to a disability-adjusted life year, but factors in quality of life. But we can translate that into an economic value of $94 million. And in the same time, when we look very specifically at the chronic diseases associated with living in this more amenity-rich area, the incident cases of ischemic heart disease dropped by 2 cases per year across the 20 years that we did the simulation. So in essence, what's in our environment does have a huge impact on our health, and this is one of those ways of showing exactly what that impact is. However, we know it's quite conservative because we looked only at one type of walking and we didn't offset any other types of physical activity that people do. It's also not just what happens to our physical activity that the environment influences, it's also our mental well-being. So we looked at the relationship between social infrastructure, which has 16 different types of destinations, so things like having access to primary schools, secondary schools, childcare, having access to dentists and doctors and community centres. When you look at the association of that compared to subjective wellbeing, which we measured using the Personal Wellbeing Index, we found that there's a 2-point increase that relates to those destinations. So simply having social infrastructure around you in your environment can improve your mental wellbeing simply because you have access to what you need. So there's some more evidence, which I won't go into too much detail, but in essence, the gold standard for studies is really longitudinal data. They're very hard data sets to get hold of, but even in those analyses, there is this tendency to find that what's in the environment can have a huge impact on your health and your well-being. So just a bit of a quick summary there. So looking towards the future of our cities and how to improve them, I've given you a sense of what there is in terms of livability and those key ingredients, but what's important is to have evidence-informed policies and to implement them, actually build our cities so that they could be as healthy as possible, but also investing in them. There's a number of policies that do this, the Portland Plan, Auckland strategic plans, Smart Cities in Australia, the 20-minute neighbourhoods here in Victoria, and also Plan Melbourne. All of these types of plans are trying to bring people closer to what they need, so making it proximate and making it easy for them to get there by active modes. And active modes are super important. So I think there should be more of a focus on it. The distances that they apply to are very important. Walking recommendations, people will walk up to 5 kilometres, but actually the associations that we find in research are more like 800 metres. So if you have what you need quite close to you, you'll actually just not drive, you'll walk and you'll cycle instead. There's also a number of co-benefits that come from this. So we've kind of gone through the health ones, but also there is a reduction in car use if people have what they need in close proximity to where they live. And this means that you have air quality improvements. It's also more environmentally sustainable. Unfortunately, there are more injuries associated with using cycling. However, the health benefits in general still are more improved if you cycle, despite the fact that there are higher incidents and injuries. There are also economic benefits, and of course this is very important because it applies to the whole population, and many cities are actually continuing to grow. A big problem is that really we don't spend enough on active transport, and as it happens, for the vast majority of budgets in the last, I think, 5 or so years, it's really only 2% of infrastructure and road spending is actually spent on active transport. So we're simply not investing in it in the right way. Okay, so to our next slide. So just in summary, I've defined livability, we've measured it, we've looked at its health and economic impacts, and we've I've made mention that policies are very important in having these things implemented on the ground, and that's really what impacts people in terms of it being an exposure. Investing is very important, but the final key point is that you all have a role to play as well. You can put your hand up and speak to your local members and those in governance to say, look, this is what's missing in my environment and I want to change it. So I think that that's quite important. And this is my last slide. And looking to the future, I think also we've got some new things coming on the horizon. So we're seeing more people using electric bikes, electric scooters and electric skateboards. There are health benefits associated with this kind of transport, but of course it also needs to be supported by appropriate infrastructure. It's less clear what happens with electric vehicles and autonomous vehicles. We don't know what will happen, and if it's a business as usual kind of scenario where people are simply jumping into their cars on their own, then it's not really going to help us in terms of our health. It's really the case that you need shared mobility, whether it's autonomous or electric. It's the fact that we share it and get more people off the roads and more people being active that's going to make a difference. When it comes to drone technology, I really don't know. I throw my hands up at this one. It's really just a helicopter without a pilot, but where it will go in the future is not very clear, and that's something that a lot of transport people are unsure of themselves. So at this point, I'd just like to put that on the table for people to think about in terms of where are we going for the future. But at the end of the day, we need to make good use of our existing infrastructure in order to be able to future-proof it for these new technologies that are to come. I'd just like to wrap it up and say thank you very much for having me. And for those who are interested, we have some references for you to look at some point later. So I'll hand it back to you, John. Thank you very much.
Fabulous. Thank you very much, Lucy. That was a wonderful insight to what can be done and where the future might be. In the few minutes that remain, I think we might go to some questions from some of our members. And this one is from Dr. Robertson. And it's an interesting one because it really does cross over all of the presentations today. And essentially it asks the question, what is sustainable? And if I go to Tony first up, I think you put up a very provocative slide that showed that that cities are growing much faster than rural populations. And if the rural sector is contracting, that's a zone that Joe's told us may have less pollutants and may have less allergens potentially. And we've also heard that, according to Meredith, the rural sector is as well connected as anybody else. So, Tony, do tell us, what do you think about sustainability and the rural sector?
Yeah. No, thanks, John. This is a really important question. And when we look back and reflect on the report, Our Common Future, which really introduced the concept of sustainable development to the world, led by Dr. Gro Brundtland, who, as it happens, was actually a medical doctor in Norway before she chaired that process. At the heart of sustainable development is really an understanding of our responsibility for the health and well-being of future generations. So yes, we need to think about health inequities among people currently alive in the world, but we also need to think about our legacy, and that's what's different. And so we need to think about what the decisions we make mean for the potential for the flourishing of future generations.
Okay, that's an interesting perspective, Tony. I'm just going to take this in a slightly different direction and now just go to Lucy about her predictions for optimal cities of the future. Having heard what Tony just told us, what do you think about rural living? And are your predictions extrapolatable, if you like, to the rural sector?
Yes, I think they are. Well, I think it's a complicated. It's tricky to answer actually for the rural sector because livability for the rural sector is different, and it's something that we're still working through in terms of defining it. So I think there are some lessons to be learned from what we know that what happens with large cities. So whether we need to worry about autonomous vehicles or electric vehicles, I think there's great potential. What we are seeing with some of the rural cities is that they are starting to make the mistakes of larger cities. So there is this sense that the livability in the inner city areas tends to be quite good, but as you grow those cities larger and larger and larger, you get these problems sprawl starting to emerge. Also, people in rural cities some of them have to travel very, very long distances. You can't ask those people to ride a bike to work. It's just not going to work. It's not possible. So I think there's a tension, there's a difficulty in defining it, but it's certainly possible to use the lessons learned from larger cities to apply that to regional ones.
Okay, thank you. Let's go really rural. The next question comes in relation to Indigenous health. And Meredith, what do you think about the capacity of our Indigenous communities to be able to engage digital health? And I wonder if you have any views on Australian Indigenous peoples, and as well as that, on Maori Indigenous people.
Thank you, John. Yeah, the issue of digital inclusion is one which is a really important subject of discussion at the moment amongst certainly Aboriginal and Torres Strait Islander communities and Nungo. And the Australian Digital Health Agency has had a very strong program of work in terms of working with Aboriginal and Torres Strait Islander communities to make sure that that support services or education, etc., about what people might have access to in communities, like accessing their own health information through My Health Record, for example, should they choose to have one, is appropriately delivered, culturally appropriate, and delivered by people who are trusted amongst those communities, and it's the message is clearly understood. And I think it's really important to acknowledge the fact that closing the health inequity gap that's experienced by our Aboriginal and Torres Strait Islander people, particularly people in rural and remote communities, is a key aim of the work that we're trying to do across all of the National Digital Health Strategy, but particularly in that Communities of Excellence program. I'm afraid I can't comment quite as eloquently on what's going on in New Zealand. There may be someone else who on the panel who might jump in and make a comment about the Maori situation, but my understanding is that they also have similar issues with respect to those social determinants of health which can impact people's access to health systems and services that people in cities simply take for granted. Another thing I wanted to mention was that the work that we're doing at the moment with NBN, with the National Broadband Network around the country, is around trying to make sure that we get better services delivered to communities who simply don't have the bandwidth to do things that we take for granted in cities. And those things are around things like video conferencing for telehealth rather than a phone call, and other aspects of connecting up isolated practices, particularly Aboriginal medical services in isolated communities. So we're doing some work with some communities in the Pilbara at the moment, which it's like a 12-hour drive from Port Hedland, one of these clinics, and they're simply unable to do all of the things that we take for granted in terms of looking up the national digital infrastructure, looking up My Health Record, having a telehealth consultation. And it's so important for people who are so isolated to be able to actually stay in their own communities and get their healthcare delivered there, not have to travel literally for a week, sometimes to get to, say, Perth for an appointment with a specialist. So really important stuff around that.
Thank you. It was a slightly loaded question because the RACP recently finished a survey of 1,000 members in relation to advantages of telehealth, and we were delighted to see that we believe that Indigenous participants had one of the greatest advantages from telehealth, and that does give us an open door to pursue this further in relation to Indigenous communities, so thank you for that. I pick up on something on a related matter that Jo mentioned at the end of her presentation, which was in relation to education about the environment. So I'm going to Jo now in a question from another member, which is that does education naturally then lead to better health outcomes? What do you think?
Well, I think we know that education is insufficient to lead to better health outcomes without better ways of implementing some of the changes and making sure that we are So knowledge in itself, just acquiring knowledge, doesn't necessarily change health outcomes. So health literacy is more than just knowledge. It's actually being able to act on that knowledge and having the capacity to do so. So I think we need to think more broadly than just a straight education approach if we're going to make a difference.
Okay, thanks, Joe. I wonder if the other speakers have a view on whether, as we've seen in relation to urban and rural populations and the divergence that's occurring, have we got a divergence in health literacy? And have we got a gradient now appearing in the haves and the have-nots? Tony?
Yeah, I might just make one point here, John, around the fact that people living in rural and remote communities, whether it's in Australia or New Zealand or around the world, are much more in touch with the natural environment than people are in large cities like Melbourne and Sydney and elsewhere. And I think that that means that they're more in tune, in fact, with the importance of the natural environment for our health and well-being. And so I think that's a real strength that comes from rural and remote communities that we all should benefit from.
Thanks, Tony. I've got a question that's come in from Dr. Wong, who's asking about the role of the Australian digital health infrastructure in supporting management of the COVID-19 outbreak. Are we tough enough? Do we have the right controls? Should the government be having more of a say in relation to tracking and safe apps? What's your view, Meredith?
Yeah, well, John, look, as people may be aware, there's an app out there, the COVID Safe app, which is actually run by another agency of government, the Digital Transformation Agency. So I'm not across the detail of people wondering about the particulars of how well it's working at the moment, but certainly supportive of us all downloading and attempting to support contact tracing and that sort of thing using apps like that. And I think that's certainly an example of a digital health innovation which was rapidly taken up by the community in a time of crisis. And I think the COVID-19 pandemic has been something that's driven us to make changes much more rapidly. So I think, look, it's probably a fairly big question, that one, but I'd like to point to electronic prescribing as an example of something that through the COVID-19 crisis, we've accelerated rapidly, and we're now in a position where we've got a working system, given we're just getting software in place now in practices and pharmacies, that there is now a system in place which is a legal electronic prescription. I can write a script from my practice, it will automatically arrive on my patient's phone as a QR code in a text message form to them. They can forward that to a pharmacy of their choice that also has the supporting software, so it sucks up that QR code. The pharmacist can legally dispense that. That is a legal prescription, and then they can actually deliver that medicine to the patient at home. So all of that was rapidly accelerated, which would have been a piece of work which we probably wouldn't have seen for another 2 years in real life. And that's as a result of things that are pushing us along with this COVID crisis. And of course, the telehealth item numbers that we're all using at the moment in a huge way are likely to be something that hopefully will be extended, because we're realising there's a lot of good work that we can do using video conferencing and phone conferencing, which is much more convenient for people when it's appropriate to use. So some interesting changes as a result of the pandemic.
Thank you very much, Meredith. As usual, technology moves faster than doctors can write policy. So thank you. And on that note, I'd like to thank our speakers. I'd like to thank Tony, Meredith, Joe and Lucy, and of course we must thank the Australian Digital Health Agency for their sponsorship. Thank you everyone for joining us today, and I hope you'll come along again to the next shared session in the RACP Online Congress series. Goodbye now.